Happy New Year, everyone, and thanks so much for joining in today. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, COVID, RSV, and flu updates on the Tripledemic. Just a reminder that this educational series is very generously sponsored by a partnership between the California Medical Association and the California Health and Human Services Agency. Next slide, please. Here are our speakers' disclosures today. Next slide, please. This is our agenda for today. Next slide, please. And just a reminder that we do provide CME for this series. You will be sent a survey after the completion of the webinar where you can attest your attendance. And once you complete that survey, we'll send out your certificate. Next slide, please. As a pediatrician, when this pandemic started, I expected COVID-19 to be an unprecedented time of surges in illnesses, hospitalizations, and deaths for children and adolescents. But as we all know now, that did not turn out to be the case. Pediatric offices were actually relatively quiet during the months of COVID-19 in the early months and years, while adult physicians were overwhelmed by the pandemic. This fall, however, the pediatric community certainly got their due, as well as the adult community did again, as we saw an unprecedented early surge of respiratory syncytial virus, RSV, straining our emergency departments, as well as pediatric inpatient units and ICUs. Influenza also emerged earlier than is typical, and this on top of COVID. In this virtual Grand Rounds today, we are so pleased to have Dr. Michael Vollmer, who's an infectious disease clinician from the Permanente Medical Group, to share epidemiological and clinical data and stories from the so-called Tripledemic. He will help us learn from this year's fall season and anticipate the remaining months of the respiratory virus season. Dr. Erica Pan will also join, as always, to review COVID-19 and other important California public health issues, as well as give us a look at the impact of this respiratory virus season from the state perspective. So first we'll start with Dr. Pan, and I will welcome back this amazing guest that we always have, our California State Epidemiologist and the Deputy Director at the California Department of Public Health in the Center for Infectious Diseases. Erica?
Great, thank you so much, Kim. I will launch right in. So as mentioned, we can go to the next slide. Oops, you can briefly on the agenda, I was just gonna mention, we'll talk a little bit about these three different viruses and what we've been seeing over the last several weeks. And then I know there's a lot of interest in one of the newer subvariants and really an emphasis that we continue to want to have on treatment, which we'll talk more about next month as well. Next slide. So this is a slightly different version, but of a similar graph I show you all every month. But just to give you kind of, the lower left panel is the historical context. And as you pull out and look at the last several months, you can see the black line is sort of the peak of our cases. I see we're having some technical difficulties that happened sort of when you look at when the cases actually happened, that peak was actually a few weeks ago, and then hospitalizations have been relatively flat and stable, with maybe a slight increase. This is 7-day averages, of course, but over the holidays. And then really importantly and really good to track as well is that deaths thankfully have remained low despite some of those larger increases, and we did have a little bit of an increase, but not nearly as much as when you look at that historical context on the left, and also that our ICU even has not been as impacted with recent subvariants as it has been earlier in the pandemic. Next slide. The other thing we look at, because, as we all know, a lot of the testing is happening at home now and not necessarily reported to public health. We are looking a lot at our wastewater surveillance across the state and in different regions. And we've had a little bit of less data coming out during the holidays, but of what we can see, we definitely see plateauing or even decreasing in different parts of the state as of last week. And we'll have some updates this coming week as well. Next slide. So also just to put this in context to prior seasons. So as Dr. Newell mentioned, we certainly had a much earlier flu season, as you can see here, compared to prior years. And many times, including on this Grand Rounds, many of us have talked about the last severe flu season we all remember. It was also a flu A heavy, H3N2 heavy season, was 17-18. And that's what that highest peak, orange peak, is there. And that's when we really saw an even higher flu hospital admissions, at least for our statewide data. And then what we saw again this year was much earlier and definitely higher than multiple other seasons outside of that 17-18 season as far as a peak. But thankfully, again, we're seeing that decrease. There's been a little bit of a bump again more recently, and we'll see, what happens moving forward. We often do see a little bit of a two-peak curve with our flu seasons, hoping that maybe that we are out of the worst of it, though, for this flu season. Next slide. Let's go back one again. So also RSV, which I know we're going to talk a lot about when Dr. Vollmer comes on, but just to show you, and this is only, admittedly, this is only 3 counties in the Bay Area. We have a California Emerging Infections Program. It's one of several sites across the country that CDC sponsors that has intensive surveillance that is really since RSV is not a reportable disease, this is kind of more intensive data where they have surveillance officers really looking at lab confirmed hospitalizations. So in that 3-county region, you can see prior seasons compared to now. And actually in 2019, before the pandemic, we had a pretty severe RSV season as well. When you look at the hospitalization rates per capita and had a similar peak to this past year. Again, we had a much earlier peak this year and certainly more serious than the few prior seasons we had in the pandemic. And you can see this really dramatic, almost no RSV at all during that first winter of the pandemic. And then last year we saw a little bit come back, and then certainly this year was much more severe. Next slide. Another way we have been looking at all of this at the state is looking at total hospital census, and then we have added to what we had been tracking really closely as far as COVID, what we're seeing as far as percent positive patients that are hospitalized statewide and by region for flu. So to orient you to these panels, you can see the different regions, and then the lower right-hand corner is California. So that green line that you see at the top, we've been monitoring what we've been calling a baseline of 100% is sort of the naders during the course of this pandemic. We actually didn't have a mechanism to collect statewide hospital census data until the pandemic, but thankfully now we do have that. And so the times we've seen our hospitals get into the most trouble is when they are over like 15 or 20% of that baseline. And so you can see that did happen this past season. And so that's all comers, respiratory, viral infections, and others as well. And you can see, as we all know and felt, and again, you'll hear more about the on-the-ground experience. This winter, we saw, for a sustained period of time, the total hospital census in California was over 20% above that baseline and was really stretched. As far as what contributed to that, so this is kind of the stacked version. The blue is the flu cases, and then the red is COVID, and those are percent positives down there. And when we've seen the most impact on our total census has been when COVID, at least during the pandemic, when it was above 15 to 20% positive in the hospitals, that when it really pushed a lot of those total census over the edge. So you can see as far as trends too, we had a high sustained over 20%. There was some decrease and maybe a little bit of a post-holiday bump happening here too that we're monitoring closely. And again, you can see it's really different in different regions. But COVID and flu did seem relatively flat over the holidays, and we may see again a little bit of a residual, since there's always a delay of a bump post-holidays, but hoping that again we're out of the woods and out of the worst for this winter season. Next slide. And then as far as projections, so you can always get to this model on our state website, CalCat, but you can see that again, thankfully, this also is projecting that our statewide COVID hospitalizations will continue to decrease. Next slide. And then for flu, we also are projecting, this is kind of an ensemble as well. Our blue line, that thick blue line, is the ensemble that you can also get to on our website, and it is projecting decreases in flu hospitalizations as well. And there's a couple other flu models with their kind of margin of error there that you can see. So there is a spectrum, and in some of these models, it could really increase again and get close to the peak that we saw a couple months ago, but again, the projections are that we are having positive trends moving forward. Next slide. So to give a little bit more historical hospital burden context as well, you can see, and I apologize, it's a little bit busy, but I'll try to walk you through this. So there's, RSV certainly, of course, impacts our young infants and toddlers the most. And actually, the other point I should have pointed out on that CEIP slide with RSV is that we did see, and we forget because our burden on pediatric hospitals was really what was stretching our resources the most this past winter, but there was a bump as well in over 65 RSV cases this winter season as well. But as far as total census, it really has not been a big contributor to that. For example, when we get to over 50,000, for example, in California, total hospitalizations, if only 1,000 of that is about 1.6% of that has been RSV at a peak. And then we have some parameters to look at total flu and pneumonia historically, and then our peak COVID census during that very worst winter surge was 22,000. So almost 40% or 40% of our hospitalizations were actually COVID when we had those first really severe surges earlier in the pandemic. And then compared to now, we probably have a total of about 5,000 COVID and flu combined. And so when you look at the graphics, so the winter surge where we had that 22,000 and that first winter, we had, again, over 22,000. And then the Omicron surge, we had around 15,000 that were COVID. And then to compare to a 17-18 severe flu season with about 5,000. So it's a little hard to see, but where it says current there and that solid line is kind of where we are now, where we were just under 5,000 and hopefully improving as well. And again, just a lot earlier of a season than historical flu seasons. And then you can see like last year when we had that Delta surge in the early fall, it was still under 10,000 that were in the hospital with just COVID. So again, some historical context. Next slide. And before I start talking about the subvariant, I think the last thing, of course, and I'm sure this will get covered a little bit more as well, is that while historically we had a much lower hospital census overall, we were really impacting our pediatric hospitals, which have a much narrower number of staffing and beds, and also just a very, very tired workforce. So after 3 winters of this pandemic, I think we've certainly lost a lot of our healthcare workforce, and staffing was clearly the biggest issue in all the hospitals we were hearing from as far as the stretch we saw this winter. So shifting gears, there's been a lot of media lately about the newest subvariant and what's happening with that. So XBB 1.5 is still a subvariant of Omicron. And we are seeing, that's the latest one that seems to be increasing in proportion, especially in sort of the Northeast. There have been some variations actually in what the CDC nowcast estimates. I've seen as high as 60 to 80%. I think they maybe had just adjusted this number, but in general, a much higher proportions are being seen in the Northeast of this particular subvariant. We in California are estimating we have anywhere from 5 to 15%, and of course, we'll continue to be monitoring that closely. It does seem to be increasing in proportion. The other recent ones that we were seeing more of were the BQs, as well. So it has a relatively high growth rate advantage. It does have this mutation that has even more immune evasion. So we do expect it will gradually become the more predominant strain in California. So far, there's still no indication that it has more serious clinical impact as far as severity of illness. And it currently the US is really the largest contributor to seeing this particular subvariant. We are, of course, like everyone else, closely watching what's happening in China as far as a lot more COVID transmission and concerns about evolving variants there. But right now, of the data we've been hearing about and what variants they're seeing, they're actually some of the older versions and not some of these newer, even sub-variants that they are seeing there. But again, a lot of concerns with that much transmission that other variants could evolve. So we in the world will be monitoring that closely. Next slide. And then really importantly, we continue to want to make sure we emphasize how important treatment is and how this is a tool that we didn't have in prior winters, especially something that you can take as an outpatient, take for a few days that can have a broad impact, and seeing a lot of barriers and underutilization. Next slide. Our teams looked at a survey of health systems, sort of websites and plans, insurance plans or health systems, and tried to categorize them into these 3 different levels that you see here. And level 1 in orange was really, there was like no information about patient treatment or information that wasn't quite up to date, like there's a scarcity of treatment supply, which would be sort of outdated at this point. Level 2 would be that they just say, well, if you're seeking treatment, look at the CDC website or go to a federal test to treat site, which there are very few of in California, or just contact your primary care provider. And then level 3 was categorized as really clear information for patients about what they can do next to seek treatment if they are testing positive for COVID. And you can see the trends here. The trends at least are in the positive direction, but when our teams looked at this in August, 2/3 of the health system sites had no information about treatment or again, outdated information. That's gone down to about 47%, so half, but still half of these websites, so half of the patients out there are trying to find information and are not getting clear and up-to-date information from those health systems. Again, some improvement has happened over the last several months, but we want to continue to work with all of you as providers as well to make sure you have the information you need to help provide treatment to your patients. Next slide. And then we sent out this health alert actually a couple weeks ago, and we mentioned this last month, but it just bears repeating because we again continue to hear that people are not getting the treatment they need even when they're seeking it, and they're very clearly eligible and could benefit from treatment. So we sent out a health alert about providers really, we all recommend that all of you have a very low threshold to treat, and that you should really only not treat when the risk clearly outweighs the benefits. You see decreased risk of hospitalization and death, and early evidence for decreased risk of long COVID symptoms with treatment as well. And just some misinformation we're hearing about there anecdotally from patients or individuals about why their providers are not providing treatment are because they've been vaccinated, because they've been infected before, if they only have mild disease, or some providers think you need to actually do lab testing in order to prescribe treatment, and none of those things are actually necessary as far as treatment. So even people who have been vaccinated, even people who've been infected previously can benefit from treatment, and continuing and ongoing data about that. So we have more references on that online. Next slide. And then I know last month I asked you guys about this, and it was really helpful to hear that, one of the biggest concerns and barriers can be drug-drug interactions. And so wanted to highlight a few key themes around that. And this also is just highlighting again that you're reducing the risk of hospitalization or death by 50 to 88% in these patients, depending on whether they've been vaccinated or not. Most medications don't have any drug-drug interactions. Some might require a brief pause, some dose adjustments, or just specific patient counseling. And that includes some of the statins, some of the antiarrhythmics or anxiolytics, anticoagulants, antipsychotics, and calcium channel blockers, sildenafil. Those are some key ones that might, again, but it might just be a minor pause, like hold on this medication for a few days while you're on Paxlovid or other things. There's very few drug-drug interactions that are absolute contraindications, and they're listed here. And here's a helpful website as far as drug interaction checkers. Next slide. And we're really excited to share that there's a new COVID-19 therapeutics provider warm line. It's a national clinician consultation center. It's actually started just yesterday, but there's a 1-800 number that you all can call, and you can get real-time free consultation on a patient in front of you. It's managed here in California at the UCSF, and you can, again, it's a warm line. You can speak to a live clinician or pharmacist about these drug interactions or any other concerns about treatment, and no protected health information is collected. It's really just for that help and consultation. And there's also a new webinar series from SMEs and other clinicians that will provide CME about treatment as well that's coming. And so those links will be on these slides. And then we have a new treatment communications toolkit, which we are really disseminating widely, and hope that you can help us disseminate that as well. Next slide. And I know next month we're going to focus even more on treatment. We'll have some other subject matter experts really focus on treatment, but wanted to make sure we continue to get that message out to all of you, especially as we are on the heels of high levels of transmission. And I think wanted to wish everyone a happy new year. It's a new year, and how are we all thinking about 2023 and beyond? And I may have shown a different version of this slide and quote previously, but I think, we're not going to stop the waves of COVID-19 transmission, but we can learn to surf, and we can use the tools and lessons learned we have gained during this pandemic to help us improve and mitigate other respiratory viruses as well. So we're going to continue to adapt to this virus as it evolves. Again, really improve on the tools and lessons learned from COVID-19, and hope that we can improve our response to other viruses as well, and really continue to focus and prioritize our most vulnerable, really with equity in mind, having interventions, for example, in long-term congregate settings and SNFs to prevent the most morbidity and mortality. So thanks for all that you're doing, and Happy New Year, and I'll turn it over. Thanks.
Thank you so much, Erica. I will just say that last slide is very inspiring, but please do not go out and surf right now if you're in California on the coast, because there's a massive thunder and lightning storm. Don't want to be that inspirational. But now I would like to turn it over to our other guests. We're so grateful to have Dr. Michael Vollmer. Dr. Vollmer is here with us, and he currently serves as the regional hospital epidemiologist and the co-chair of the Regional Infectious Disease Infection Prevention Committee for Kaiser Permanente in California. He also continues to work as an infectious disease physician in the Napa Solano area for the Permanente Medical Group. He completed a fellowship in infectious diseases and a residency in internal medicine from the UCLA, and received his medical degree from the University of Minnesota, an undergraduate degree from the University of California at Berkeley. I'm in the middle of a hailstorm, so I'm going to turn off my sound, and welcome.
Thank you, Dr. Newell Green. Hailstorms remind me of my time in Minnesota, but here we are in the Bay Area. And thank you, Dr. Newell Green, Dr. Pan, that was an excellent intro to the EPI where we stand today in California. Thank you to the CMA audience for inviting me. I hope I can tell you a little bit about how we've tried to respond to these challenges now in the third year of COVID, and with a real respiratory virus season this fall in 2022 leading into 2023. Next slide. So I'm going to try to hit a bit on surveillance that we do region-wide in Northern California, how that generates data, both syndromic as well as lab, that can then lead us into operational shifts and changes. And ultimately the goal being that we want the provider, the physician, our nursing staff to be as well informed as they can to affect patient care. So it's a bit ambitious. I'm going to be expanding beyond just RSV, but hopefully it tells a bit of the story that we've been dealing with. Next slide. So again, we're fairly large. We have a large footprint here in Northern California. We're 4.6 million members. We operate 21 acute care hospitals in Northern California. We have licensing with additional facilities, over 200 medical offices. We're almost about 10,000 doctors and 85,000 employees. So just to level set, that's about, in terms of membership, the size of a country like Ireland or Costa Rica, slightly smaller than Denmark and New Zealand. It's a lot to look after in terms of trying to keep employees safe, trying to deliver care and keep our members safe and healthy as well. In addition to which, with all of the facilities, we're dealing with a number of local Department of Public Healths, which we want to maintain excellent relationships with, in addition to liaison with the state as well as national public health, as well as regulatory bodies. Next slide. So really, I want to start a bit first talking about surveillance and monitoring, and this historically taking a step back, that really has started with our call center data. And monitoring, sort of as the first point of entry for care, patients calling, what are they calling about, what are their complaints, keying in on ILI, influenza-like illness, upper respiratory tract infection, symptomology. And now a lot of this work started also out of the Department of Research and Vaccine Studies on influenza. There was work by Dr. Roger Baxter, as well as Dr. Randy Bergen carried it through over the last several years, disseminating this kind of information to the physician population at large. We've developed pretty robust lab reporting and lab services that utilize our both regional and local laboratories. And then how we use this data to identify, collect, and share to ultimately lead to operational shifts. Next slide. So again, looking at that appointment advice call center, this is a graphic that's distributed widely in Northern California, and it allows us to track call volume for specifically when an upper respiratory tract, when a member is calling in with those kinds of symptoms, this keys. And you can see here the last 3 years of data for URI like symptomatology has tracked our fall surges, and this will usually precede our lab data and any sort of acute care visits, including ED, by at least a couple weeks. You can see the yellow and the pink represents the last couple of years, and that was all driven by COVID. There really, as we just went over again, there was no influenza. And then that dark navy line from 22-23 is where we're at today. And you can see that very early rise happening at the end of October was driven by probably a number of respiratory viruses. We'll talk a little bit about RSV next, but ultimately we were seeing an increase in probably a number of different communicable diseases, ultimately leading into flu and SARS-CoV-2. I can say that the call volume has been dropping over the last couple of weeks, indicating that we may be coming through this most recent community surge. Next slide. So here's our influenza data, and similar to what Dr. Pan showed, you can see that we had, again, a very early rise in our influenza cases here in Northern California as compared to past epidemics. The green and blue bars represent 2018 and 2019, the last two times we really had flu activity in Northern California. So you can see that very early and rapid rise, peaking right towards the end of December, and then a very rapid descent. Not unusual in the epidemiology curve, where the slope up often is reflected in the slope down coming off of these curves. And again, at the bottom, you can see the almost minimal activity in 2021 and 2020. I would say that a huge super majority of these isolates are influenza A. And then next slide. This is combined with what's happening with COVID and RSV. RSV here in green, again, peaking, coming on very, very quickly, 6-7 times what we had seen in previous RSV surges. And this was definitely not predicted, put a lot of stress on our pediatric departments and EDs in terms of call volume and visits, and even inpatient observation and some admissions. And then as RSV was declining, we see this increase in SARS-CoV-2, which we may have plateaued over the New Year's period. Interestingly, since we have no prior data about co-infections, and maybe from this fall beginning to understand a bit about how these viruses may cycle with each other, we saw very, very little, less than sort of 0.5% of co-infection this fall. And the only prior data that I'm aware of was very early in that 2019-2020 flu season that dropped off precipitously with all the community mitigation that went in place. But there's something more here about co-infection, where there may be an inhibitory quality that we're seeing, where people, if you're infected with one of these viruses, it may be much harder to get a second virus on top. I think that's another story that we'll learn more coming out of research as we head into 2023. And it'll be interesting to see at a population level how these viruses are co-circulating. Next slide. So here's our inpatient hospital census data from COVID-19. And in the bottom left, I'm going back a year ago, similar to what Dr. Pan showed in terms of the Omicron surge, was really the last real big surge of COVID disease, where the hospital census peaked at around 25% roughly, was COVID-19 right around New Year's. You can see our summer surge, which was driven more by the Omicron derivatives, BA4 and BA5. And then finally, what we think has been driven by the BQ1, BQ1.1, maybe some early XBB coming in there that we'll later identify, given that the genotype tends to lag. I can say further that the relative morbidity, mortality has remained low. You can see in the bottom right, there's our ICU census, which although has remained high, the overall percentage of COVID-19 has remained relatively low, something lower than 5% through these last couple of surges. I also wanted to say that if you take a snapshot of the census in our hospital right now, roughly 70+% is over the age of 65. So you see some maturation of the pandemic. It continues to target those most vulnerable, primarily those over the age of 65 and immunocompromised. And another facet, as we look at how we're doing our surveillance and lab testing, in the top right is an attempt at trying to parse out who's actually being admitted for COVID-19, meaning symptomatic, on oxygen, getting steroids, on remdesivir, and that has stayed roughly around 50% over the last couple of surges, indicating that potentially that we're not seeing any change in the virulence in the organism, and continuing to see vulnerable populations primarily being affected, and those that are unvaccinated. Next slide. And so a big aspect that I did want to touch on too, not only just therapeutics, but also importance, and particularly as we're seeing new variants of vaccination. And on the left is our COVID booster percentage, and as well on the right is our influenza vaccine percentages. And I wanted to show the general population percentages on top, which is roughly around 30% and climbing slowly. But really, our ability has been to try to protect our most vulnerable populations, and it's not where we want to be. And the uptake certainly has been concerning and something that we continue to evaluate. But you can see there that over 65, we're close to 55% of our membership has gotten the COVID booster, which really has more importance as we see these variants emerge, and as the virus gains ability to get through existing immunity, that boosting, particularly with the bivalent, and for our populations that remain vulnerable, despite getting the primary series, which by the way, we're over 80% of our membership has gotten the primary series. It's really important that our physicians continue to message and give that opportunity to get that booster dose. We'll obviously get more information into 2023, how effective that has been in the fall. I know preliminary reports, MMWR, continue to show benefit in reducing morbidity and mortality, but looking at that new variant data, it's become, I believe, even more important into 2023 to get people that bivalent booster. And then again, looking back at the flu and our rates there, it's been disappointing. And I think one of the things that I'm going to be emphasizing is we're going to be continuing to deep dive and learn, already preparing for next year, how we can get these percentages up, and learning and getting feedback at those points of care when people are choosing to get vaccinated or declining. Next slide. So one of the things I really wanted to highlight was, and it also in terms of other outbreaks around the country, was how great our pediatric department has been at keeping up with routine pediatric vaccinations as a barrier to outbreak. And here you can see that we've stayed well over 90% for our membership in pediatric age groups at getting polio and MMR vaccine, and the combo 3, which includes a whole litany of vaccines, close to 85%. And this is in the setting where there was school closures. There wasn't those opportunities to get parents, to get kids to come in, to get vaccinated, that they've really utilized those points of care to continue to get shots in the arm, which really provides us a great barrier of protection against outbreak. And you've certainly seen those stories, and I think it's been talked about in this webinar, where the polio issues in New York, where vaccination rates have dropped as low as 50–60% in some counties, and the measles outbreak in Ohio in the same story. And certainly we've had those issues in California in the past, and so this was very reassuring and a real point to highlight again with our pediatric departments of what a great job they're doing, despite having to deal with RSV and all these other things. Next slide. And so really all of this coalesces into these different departments taking this data and having a surge response. And of course, every facility from an ED disaster sort of lens has their own local surge response and can flex into auxiliary space, make use of things like the post-anesthesia recovery units, if they need extra ICU space, if they need to pull in equipment, we have tracking on all our ventilators, et cetera. That kind of level hasn't been needed really since 2020, 2021, but it remains there. And certainly our hospital census, even with what Dr. Pan described as this additive effect of these various respiratory viruses, there still is a lot of pent up care that people are needing. People are coming in not having taken care of their diabetes or hypertension. We're seeing a bit more higher on the scale from other diseases, has continued that hospital census to be high outside of the infectious disease realm. Our critical care, luckily, has had a bit of a break from COVID-19, but I think, as was alluded to by Dr. Newell Green, they're tired. And I think sustainability is really the key for our ICU folks, especially as they're now dealing with all this litany of other illness. As was mentioned, pediatrics was very challenged. I think that surge of RSV came on very quickly. We use call center data to try to quickly adjust the type of appointments that are available. If we can adjust to telemedicine, and that's helpful in terms of providing advice, that can be great in a pediatrician's schedule. As much as possible, there's attempts at what we call e-visits, where that call center will generate an email to a patient and family with general advice, hopefully saving the pediatrician from having to make a call or a visit and repeat sort of standard approaches to things like RSV. There's a tremendous amount of prevention and outreach and member education. Once we see call volume going up, we see those lab numbers going up to try to get ahead so that people aren't coming to the emergency room for care. And then when the ED is overwhelmed, as can happen, and those wait times back up, and there's borders in the ED, are the ability for our pediatric hospitalists to come downstairs and start rounding and taking care of kids in the ED is another flex option that we have. Again, highlighting with our appointment and advice line, there's surveillance on call volume on URI that goes around year round. And there's a lot of work in terms of also forecasting with that data. That leads in the ability to flex scripts and telephone treatments, and all of that can be driven through leadership and physician consultation. So that's happening in real time. And I'll say too, when we look at things like our vaccination rate, there were multiple waves in the fall of trying to get member education, member outreach, trying to re-emphasize the importance to members of getting themselves vaccinated against the flu. And we even started vaccinating early in September of 2022, anticipating, given the past 2 years of data, that we would very much likely see a fall surge. We just didn't think it would happen quite as early as it did. The other thing I'll say about our call center is that all of the nurses who work those lines are backed up by emergency room physicians that can also help triage if there's any actual need for acute care, and how to do that and alert the local facilities that may be coming. And also, given what's happened over the last couple of years, it's really important to emphasize how much our call center triages mental health questions and tries to get people care on that level as quickly as possible. So again, I briefly mentioned, I won't go too much into depth, our lab does a tremendous job trying to provide both regional and local support, both for turnaround time as well as specificity. They do a lot of tracking and sharing of data with the Department of Public Health in terms of reporting influenza, also sharing COVID isolates to try to benefit the genotyping data that you saw earlier in the presentation. And then finally, a lot of advances in informatics. I mean, all of this is about supporting decision-making and operations in real time, and continuing that journey in terms of also developing predictive analytics so that we can put the resources where they need to be at the right time at a particularly challenging time in healthcare. Next slide. So one great example here is the team that developed a COVID therapeutics tool. And you can see on the left, frontline physician can use this to put in information about a patient that will then on the right help them decide about what type of treatment they need for COVID-19 and how to execute that. If there is any lab work that's needed, it leads them right in through the EMR, how to order it. And so there's as quick as possible at point of care, people are picking up medications and getting started on Paxlovid, for example. This tool also was very helpful in terms of when the infectious disease physician group, as well as other subject matter experts, noted the increased transmissibility of variants this early, sort of September, October, and reports coming out about the decreasing ability to monoclonal antibody to effectively treat early COVID-19, and pivoting away from some of those products and trying to promote the ability to give remdesivir as an outpatient is another example where once this tool was developed, it could be modified in real time based on data that was coming both nationally, but as well as from the state about changes in the SARS-CoV-2 virus itself. But this kind of upfront and very real-time tool is where we want to be helping physicians make these decisions as quickly and as efficiently as possible. And I think for all doctors, less clicks on the computer is always better. Next slide. And so this is also a real problem that we dealt with, as I think everybody dealt with in California this fall, and that was the cupboard was bare. And this is my own photograph of a local retail pharmacies area trying to pick up Tylenol. And we had those issues as well. And this is just part of an ongoing story of supply chain services. And this time it was medications and pediatrics, liquid formulations, antipyretics, some of the antibiotics. Early on in the pandemic, we as everybody experienced supply chain issues. And where these resources come from, it's primarily Asia. And not only have we talked a bit about what effect the variants will have with China opening up, but one does wonder, like long term with these international supply chains, like how that affects American medical systems and where we get our stuff. At various points during the pandemic, we've had to deal also with even surgical supply issues. And so our supply chain has really done an amazing job trying to look for multiple suppliers, trying to make the supply chain and stock as efficient as possible. We've certainly, per CDPH and governor's orders, stocked up on PP at this point, so that's a non-issue. But really here too, there's a sustainability question that I think we're all looking at, and how we can have a supply chain more firmed up for the long term. Next slide. So while we're looking through all these areas, and I won't go into detail on all these, just mention a few highlights that when we're talking about ED, pediatrics, critical care, I mean, all of it comes down to staffing, and staffing with physicians, staffing with nursing staff, all the other personnel, respiratory therapists, EVS. I mean, all of this is strained now 3 years into COVID-19. We, as an integrated system, have the ability to move people around where others may not. Certainly, some physician redeployment has been possible and continues to work. But we've also just noticed that, we're at capacity, and we have a lot of people needing care. The pediatric issue is certainly one we can talk about a bit in the Q&A. They're just, holding pediatric beds when there aren't kids that need them is a tough thing to convince hospitals to do. So how can we flex? In some ways, early in the pandemic, it was much easier to flex adults into pediatric areas of care. Doing the reverse seems to be a little harder. Getting hospitalists to be able to effectively care for people between the ages of 12 and 18, and finding nursing staff that are licensed to take care of kids less than 4. Those are things that we're going to continue to be working on scope and education so that we can have that kind of capacity. The other thing with pediatrics that's clearly needed, but has some regulatory hurdles, is how can we maximize urgent care? How can we get kids, with allergies and wheezing, nebulized therapy safely without having to send them to the ED? Those are things that we're constantly looking at and reviewing. And again, trying to also keep all the real-time short turnaround time, lab testing that drives a lot of this, and the centralized but also sharing of all the data that we're gathering so that local centers can make these decisions as quickly as possible and keep people moving through places like the emergency room so that we can deliver all the other care that we still need to do on a daily basis. And really, again, highlighting how amazing the data is that we get and the help we get from our appointment and advice center that disseminate all that information early and potentially give that early and but very specific warnings about these things that are coming in the next couple of weeks. Next slide. So I did want to also briefly mention, how important it's been that we've, through this, partnered with California Department of Public Health. It's really been a collaborative and relationship building that's happened. I think that's been tremendous over the last 3 years. I think, for example, the sharing with our Department of Research and our lab, the information that has allowed a lot of the genotyping to occur across California has been exemplary. We really look for as much possibility to automate and consolidate data reporting. Again, we work with a number of different local departments of public health. When we're trying to do the reporting, it puts a lot of workload on our local infection prevention staff if those asks are different from different areas. So as much we can, we're trying to work on standardizing that kind of reporting and automating to, again, eliminate a lot of the clicks and the paper trails because our staff is just tired and we really need them. And so we also always want to understand too about how that data can be used to better the health for our patients. Next slide. And so just a few takeaways, like we've really tried to emphasize data-driven decision making. We're a huge organization. We're trying to be flexible. It's a daily challenge, but trying to flex with unpredicted and very rapid onsets of things like the RSV that occurred in November. We were gaining a lot of learning about how we can do that better. Even with all the experience with COVID-19, we still have ways that we have to learn how to be more nimble. Communication is key. So communicating with our employees, with our membership, making sure our physicians are well informed, because that's going to really allow them to promote good, healthy decisions, like things like taking Paxlovid, getting bivalent COVID boosted. That makes that happen. That gets shots in the arm, because an informed patient is really going to be better protected. And I can't underemphasize the ongoing need for both regular routine pediatric vaccination, as well as those same considerations in adults. And I think there's a lot to be learned from the pediatric experience and how they get shots in the arm in the adult sphere. And so all of this is really really about overall health promotion and allowing access to care, which is really our barrier against future outbreaks and epidemics and even pandemics. Next slide. So I'm not going to name all these people. There was a ton of people who helped me out, put this together. They are daily leaders in everything that they do. We have thousands of people like them and thousands of people backing those people up. So it really takes a village to get all this done and make sure people stay healthy. Next slide. And with that, I'll finish. Thank you.
Thank you so much, Michael. We'll invite Erica back on. And I'll first say that my internet has been a bit spotty, so if the sound goes off, I apologize, and I'll start typing questions into the chat if necessary. That was such an interesting story. And I know that I had friends calling me from places like Colorado saying my kid or my friend's kid needs a pediatric ICU bed and I can't get them in, and they're panicked, and what do we do? I talked to another colleague in Maine who said the nearest pediatric ICU bed available when she was trying to admit patients was in Eastern Connecticut. And so, we're really lucky to be in a state that sounds like it didn't have quite those degree of problems, but Michael, highlighting those regulatory hurdles about how do we get good pediatric care. And we know that Erica is a pediatric infectious disease doc. So I'm thinking about our kids, the scope of RNs, et cetera. I'm glad that we have this learning now so that hopefully we can push that step forward. But so really appreciative of your presentation. Maybe just you talked a little bit, Michael, about those supply chain issues, because of course we were hearing that from a lot of friends too. Erica and Michael, please step in on this as well. What do we do about supply chain issues like that? Is there anything at the state level that we can do to plan in advance for, things like running out of just acetaminophen and pediatric NSAIDs and amoxicillin? Obviously, we can't predict these things. So any hope in us getting better at that sort of thing?
Yeah, that's a great question. I do think, after other kind of shorter term disasters that, like, for example, the strategic national stockpile has done more to do like chronic disease medications for adults. I admit and acknowledge I don't know that people predicted the level of shortages that we've seen with NSAIDs and outpatient antibiotics. I do think, what can often happen is some kind of level loading. And I just want to briefly mention too, just want to thank Michael for, again, the collaboration he mentioned, but also it was just really striking me during that presentation, because as we were hearing about struggles of some of the more isolated hospitals and/or systems, I think Kaiser is a really great example of when you have that continuum of care, everything from the call center to discharge and the ED and critical care, all kind of in a unified system, you can, and having multiple beds that you can level load more easily. I think that really helps. And yeah, it's better in a big state too, as far as mutual aid. We can sometimes help other, like the local medical health operational area coordinators and or the regional specialists can help level load when there's different shortages or things like that. But it is a challenge, and you're right. I think as a big state, we have more resources, which is nice, but there was definitely, as we heard in Southern California, especially, a lot more stress on the system.
Yeah, I'm surprised, and it's kind of sad that we're still dealing with these supply chain shortages, because the reasons are known. It's just-in-time delivery, it's economics that are dictating supply, and all pharmaceuticals are made in the same part of the world and their ingredients. So if those areas have problems with production, if there's shutdown in the shipping, it all kind of, or there's massive demand. And I think the fall was massive demand. And I don't think too different than our old, there's no toilet paper at Costco. People were buying in bulk and stocking up. And you could see the little cards like, please only take 2. And that gets into some human behavior issues. So I don't think it can come from anything else but sort of like a national effort, and sort of government industry sponsored partnerships to have some, I'll just call it delta, to have some give in the system, because nobody predicted that RSV surge. I mean, you could have said, like, I think we'll see a bunch of respiratory viruses. So I think it's a combination of the economics of not supporting having margin, combined with human behavior and very sudden and massive demand that outstrips that supply chain. I'm sure, like in March, we'll have plenty of Tylenol. That's just how it has happened. It happened with all the PPE supplies. They're not set up to open more factories quickly to meet that demand. It has to happen at a very high level.
Yeah, all tricky problems. But thank you for that thought. So we have a bunch of clinical questions, so I'd like to maybe pivot to a few of those. And again, my sound was going in and out, so I apologize if this was actually already answered some of these. But someone was asking, can Paxlovid and Tamiflu be administered at the same time? Yes. All right.
Yes, they can.
Easy
It
one.
should be. I mean, when I was talking about co-infection, off the top of my head, it's like 0.2, 0.3% of our flu COVID combination cases. This is out of thousands of tests.
Okay. All right. That's actually helpful to know. And speaking of these different 3 main viruses this winter, a couple of folks were asking, do you think it's possible, or how do you differentiate between these 3 respiratory viruses based on symptoms? I've seen articles in the media attempting to sort of say, here are the symptoms. Do you have any sort of rules of thumb? That's my instinct as well, but just wanted to have the question answered. They can all look the same, or they can all look different, and it's the test that tells us, right?
Yeah, none of them are fun. You do not feel good. And it's almost impossible from from symptoms alone to differentiate. And that's why, you know, the how ubiquitous now the COVID home antigen testing really sort of drives how we advise people, you know, test for COVID first, maybe test again, and then think about flu. If you're at higher risk, then consider therapy for flu. And RSV is, you know, has no specific therapies, and really is more of a disease that affects the very young and the very old, or those that are immunocompromised.
The only thing I would add is I was a little dismayed to see some of those like media articles saying, oh, here's how you tell the difference, because I felt like that was like not a good message to be sending out. And anyway, yeah, I totally agree.
Yeah, I just want to reemphasize too, like you can test negative for COVID the first time and you can still have COVID. I mean, we've forgotten kind of we messaged that early. It still is appropriate, especially with antigen testing.
Yeah.
Super important. Have you seen specific communities being particularly more vulnerable during this fall and winter surge? Obviously the extremes of age, but other.
I mean, I'll start and comment that I think, you know, unfortunately, you know, we continue to see our most vulnerable populations disproportionately impacted. So individuals and communities of color, you know, in California, as many of you know, we look at kind of a healthy places index. And so absolutely. And I think the other interesting thing, when we were doing some of our site visits with some of the children's hospitals, when they were really struggling, the other part that we really have so little data on is, but all those patients that kind of left the ED without being seen, right? Or just couldn't access, or because there was so much overwhelm of the system, and we don't, those are the ones we have no data on, and probably are actually the most vulnerable or marginalized. So I think unfortunate themes probably are still there in our least resourced populations.
Yeah,
I completely agree, and it has to do too with the strategy on outreach on vaccination as well. Same populations that really need that opportunity, education around the importance of vaccine administration.
Well, speaking of vaccines, a lot of people are asking sort of about if you have heard anything about the future of vaccines, what's coming? Are we making progress towards, for example, an intranasal COVID vaccine? Combined flu and COVID vaccine has been sort of mooted. In the setting of RSV, is anybody talking about an RSV vaccine?
I will admit that I'm less up to speed on the latest on that. I do know ACIP is meeting again soon, just about thinking about like future recommendations, sort of more. Everyone keeps asking how often are we going to boost, and I think I saw that that was coming in. I think there's still a lot to be looked at related to that. So again, I think there's an ACIP meeting coming up to think about some of that. And then I don't know if Michael knows more about kind of what's on the horizon, but.
No, I mean, there was discussion, I think, from Pfizer about early combination flu COVID vaccine, at least in a phase 1. I haven't heard much about that lately. What I'm also thinking about today, as you know, there's reports on the East Coast of increased hospitalization, increased COVID cases tied to this XBB. It makes me think a bit about how we were last year talking about the B2 variant of Omicron. And I think, you know, our surge kind of came and went, and that really wasn't much of a factor. So I don't want to make any big predictions, but if anyone looks at Eric Topol's Twitter, which I do occasionally, he had some really interesting and provocative data there about the ACE2 binding of this variant, as well as its immune evasion, and the real drop off in effective immunity, even with bivalent boosting. So I hope that people are looking at how to reformulate, look at this vaccine, get it in easier dosing, get it together with flu for fall 2023 at the latest. But you know, that takes, again, those industry government sponsored Operation Warp Speed type efforts, and I'm not hearing a lot of that with what's going on with our representatives right now.
Yeah. Well, thank you for that. I, of course, always have lots more questions, but I think this is all the time we have today for questions. And again, I want to thank you, as always, Erica, and particularly for you for coming today, Michael, present this incredibly interesting content. And thank you to everyone who's listened in and takes the time to learn from our webinar. Just as a reminder, if you do get the survey, for CME, please attest to that so we can get you your certificates. And also CMA sent out a survey this morning to all those who attended our 2022 virtual Grand Round series. If you haven't taken this yet, please do spend a few minutes. We want to understand how you value this and how we can make it better for you and what you'd like to see in 2023. And do join us for our next session, which will be Tuesday, February 14th, and it will be around therapeutics. We'll have a lot more of the sort of information, data, et cetera. So more information, as always, is available at covidroundca.com, where you can see this and previous presentations and register for future ones. So thank you all, and stay dry.
Yeah, stay safe and dry. Thank you. Take care.